Hello. Replacing sex hormones after menopause is a lost art. The physicians who perfected this all had to cover their tracks and talk in secrecy starting in 2012. The DHEA trial made it impossible to have a continued medical education teaching physicians how to do this for women. And they also didn't allow us to have it in a medical textbook anymore. The art of helping women not have a shriveled apricot became something that I only spoke about directly to my mentors and then only mentored women who were directly my students in my clinic. It has become a better topic over the last few years, and this show tonight is about some of the things that I've only been willing to tell my patients behind closed doors for the last 20 years. These are going to be the practical steps that if you're worried about a shriveled apricot, which you probably should be if you're a woman that's my age, 53 or older, or if you have a shriveled apricot, where do you start and what's the safest place to begin? We aren't going to cover every trial. We aren't going to go through every caveat. We're going to go through what are the practical applications and the approach that I use to teach women about this really important conversation that's been muted for over 20 years. All right, welcome to the show tonight. I did have a great fast over the last 60 hours and have a glucose. Oh, I think the ketones are coming up first. Ketones of 4.9 and the glucose is, try that again. Glucose is 63 and ketones of 4.9. It is a success for me over the last couple of weeks that I have one of my kids home for summer break that probably won't ever, maybe he won't be home for another summer again, just based on his story. And we are working out together, which is one of my favorite activities to do with my kids. So I've had a couple of workouts, 2 saunas, and probably the best Dr. Boz ratio I had on a Tuesday night in 4 months, 5 months maybe. I also have a couple of things over the next few weeks that I'll tell you more about in the announcement section. Let's get into this. There's going to be questions about this, and I really am looking forward to what you are curious about and what is what questions you have. Again, this is not medical advice. I do think if you are a young physician or if you are seeing a physician who's really struggled to have this conversation with you, to have the steps that I think should be taught better. Hopefully this is a way for you to open up that conversation with your physician. And there's several things you can do safely without seeing a doctor. All right, let's begin. It's going to be a great show. Here we go. So we're going to start by saying, yes, this shriveled apricot is not unique. This is not the beginning of a story. This is an ongoing discussion that women and doctors have had for hundreds of years. But especially over the last several decades, our ability to help women with this is truly important. Tonight's discussion is going to be not about a young woman, but about a woman who's had the season of no periods for a while. She is 65 to 74 years old. Maybe you're in your 50s, maybe you're in your early 60s, but I'm really looking at if you've not had the discussion with your physician, we're going to start with some of those practical applications that an elder woman could use. And if you're ahead of that season, I think you're going to be really feel connected to caring for yourself the best by taking in this practical application. I would love in the show notes if other physicians are out there, if you disagree with this. Again, it's been one of the hardest parts about being a provider over the last 20 years is that I had some great teachers, and I hope that the pearls I'm going to teach you about tonight are insightful to how other providers might be doing this discussion. But I also would love to hear if there's other advice from physicians that are out there saying, how do you talk to your patients about it? All right, here we go. So we're going to start with step 1. And that is when a patient that is 65-ish years, or let's just say in her 50s, 60s, or 70s, coming to see me, and they want to talk about hormones. Step 1 is you cannot be a metabolic disaster. A metabolic disaster happens a lot. When they come to see me 67 years old, they have had children, they've been insulin resistant, they've had the weight on for 20 years, and now they want me to start throwing having a discussion about what we could do for hormone replacement. And your metabolic health matters greatly on how you're going to either not like me 2 or 3 steps into this, or the opposite. You're going to have a graceful discussion and a safe discussion, a safe experience on how to improve your overall health, your hormone health, while making sure your metabolic health isn't derailing our success. When I look at the number of women that have got to step 1, that metabolic disaster is not always easy to measure. But on this channel, you are not, if you're new to the channel, this might be new to you, but for most of the folks watching, you'll know that when I'm looking at somebody who's metabolically, can I use the word perfect? Metabolically perfect. Let's just say that. Their morning sugars are in that 70s to 80s. Before they eat, their blood sugar is at least under 90. When they do eat a meal, the blood sugar goes up to 130. The insulin, which they're not measuring, but they usually are measuring their blood sugar at home. Their blood sugars, don't peak over 140. They then, over the next 60 to 90 minutes, slide down into that 100 range. And by 2 hours, they're close to back to that baseline. You'll notice that the amount of insulin it took to control that person was not that much. And again, the reason why this matters is the metabolism that you are talking about for these hormones is highly linked to the amount of insulin. Now, that's what perfect looks like. Here is what most of my patients coming in to see me looks like. First, I want to point out that they start out with a blood sugar in the triple digits before they eat. Now, it doesn't necessarily mean that their morning ones can be double digits like 90 or 95, but before they eat a meal, rarely are they in their 90s. They're usually triple digits. And they start out with an insulin that might not be too high, but as they metabolize their food, the amount of insulin it's taking to get that energy put into the right places in their body is far exceeding healthy. And unfortunately, when your insulin is that high, you're going to have a tough time getting any of those positive responses from the hormones we're going to talk about. These hormones are all fat-based. And a fat-based hormone, yes, it starts as cholesterol. And cholesterol is not the demon that folks often in today's world can think it is. But cholesterol is the baseline structure that all of these hormones are made from. I want you to specifically take notice that vitamin D is one of those hormones on there, that you've got some other ones we're going to have time spent on and dive a little bit more into. But that vitamin D is a hormone that really gives me insight into how healthy metabolically is the patient in front of me, because they're coming in not feeling well. They've probably gone to their doctor a couple of times and had a holy whirlwind of a storm conversation trying to get hormones. And what it falls on is deaf ears. The physician will say, it's been too long. You can't do that. That's not okay. And in fairness, if the physician started writing those prescriptions or using those hormones before this metabolic process was addressed, it is a mess. It's a nightmare. The patient's not happy. They're calling the office all the time saying, wait, I thought you said that this was going to feel better. I feel worse. And that's because if you've seen this cartoon before, you'll notice this is the muscle in your body. This is the fat that's right next to it. And you've got these hormones of fat that are in circulation. They're going to different muscles. They're going to different organs. They're doing their job. But when insulin is high, when we have Mr. Angry Insulin over here, that hormone is put into storage. Now, those look like they didn't change at all, but I think it's worth pointing out that if these two fat cells, if you have seen this cartoon before, I have the testosterone here in blue and the estrogen there in pink, but inside the fat cells, the actual hormone that's the storage form of testosterone is the androstenedione. And the storage form of the estrogens, which is a multiple list of, it's a family of hormones, is the E1 or estrone. It's really important as you hear me talk about some of the prescriptions in a minute, because those hormones, well, this is what they're doing. They're inside that cell. They don't just sit still. They move around. They're in a place and they are ready to be activated as soon as insulin slides down, as soon as insulin is not saying, hey, put that into storage, put that into storage, put that into storage. So if you've been on these women who come in, if they've been on a high carbohydrate diet, the resources that go into a fat cell are these big arrows, and the resource coming out of the fat cell is really tiny. That is what high insulin does to a fat cell. But as you change the way you eat, the amount of glucose going into a fat cell becomes much less, and the exit, the amount of fat that you are able to mobilize in your body is much more. And some of those fat molecules are hormones that are ready to be activated and turned into a useful part of your treatment plan. In our teachings, you'll see this Dr. Boz ratio all the time. I don't do this for my health. In fact, you'll notice this when I started the show, there's always somebody who will calculate the Dr. Boz ratio. What are they looking at? They're looking at, what is my insulin relative to what it's been? So I have folks come into the practice and their glucose will be up here in the 120s or even in the 100 level. But when they first get into the ketogenic state, they'll sometimes have ketones of 2.0 to 3. And that puts their Dr. Boz ratio at a really good number, in the 50s or 60s, which says, oh my gosh, your insulin is so much better than it was last week or yesterday. And that's the tricky part about insulin, is that as your body gets healthier, it's how is the insulin talking to your cells in recent days? And that is truly what's important when you go to replace these hormones for people in menopause. When they have high insulin, it does not bode well. That high insulin state really looks at the length of time that they're going to be, or the number of times that they're going to come back to my clinic saying, I thought you said I'd feel better. I thought you said this is going to improve my energy. I thought you said, and then they'll fill in the blank, or they've gone to Dr. Google and said, that's not working. I don't have enough. Let's check the labs again. And I have learned, much like when thyroid has been a mess. I mean, it's just, we're chasing our tail with every 6 weeks thyroid hormones that just, they don't make sense with what the patient's experiencing. The same story happens when I'm looking at fat-based hormones of estradiol or testosterone or DHEAS or progesterone, and trying to predict how well the person feels. So when I say that step one is you cannot be a metabolic disaster, I look at their vitamin D, one of those fat-based hormones, and this is something we talked about this morning in our support group over at the Pin Chasers, was vitamin D is a really good canary in the cave for how well is your metabolism. Have you reversed insulin resistance, or are you suffering from insulin resistance and you don't know it? And they're the kind of patient who's just continuing to take vitamin D more and more and more and more, and their vitamin D comes back at 25. Maybe I get it up to 30, but it's nowhere near the healthy level, which would be around 50. But as soon as that insulin finally gets out of that angry zone, gets into the place where it's much healthier, boom, their vitamin D is 45, 55, 48, 60. It's in that zone where even when they're supplementing or not supplementing, even when they're supplementing, I can't get it into the 40s with most people who have a metabolic disaster hiding under there. The two other clues that I am worried about when a patient comes in and says, can I talk about hormones? And I don't care if it's a man asking me about testosterone or if it's a female asking about the stuff we're going to talk about in a minute. I, number one, say, have you peed a ketone in the last, 3 weeks? Have there been any ketones in circulation? Again, a very good sign that they're able to mobilize fat and turn it into energy. The second thing I look at is their vitamin D. Do I have a clue that they're able to mobilize one of those fat-based hormones and it's in circulation? But the third one is if they have blood pressure that is just a nightmare. It's up, it's down. The volatility and the constantly elevated blood pressure is a sign that their metabolic health is in disaster mode. And if I start throwing hormones on it, that is where we hurt people, where these hormones do a lot of important things. And when the body is not filled with excessive inflammation or those cytokines that drive inflammation, that drive high blood pressure, that drive fatigue, that weaken your immune system, when their body has those cytokines in it, I should not be sprinkling hormones on them. I don't care if it's the over-the-counter ones. All right, so let's go back to our slides. And again, we are watching for questions that you have. I know you're going to have some. So type those in, and my team is helping me to organize those. But step 2. So once I get past that, are you a metabolic disaster? And I can confidently say, you don't have to be perfect. You don't have to have that blood sugar that was in that first slide where it's, lovely and nothing's wrong with your life. I mean, no. I just need it to not be a disaster. I need to know that you are able to make ketones, that these hormones are going to help your metabolism. So we can't wait for you to get perfect to do that, but it needs to not be a disaster. But the second thing we start with is DHEA. So DHEA is a fat-based hormone, and it has, it has a, I'm going to go here. It has two very different rules from Canada to America. In Canada, you need a prescription to get DHEA, and it is a Schedule II, which means if you're caught holding somebody else's DHEA, you can get in big trouble from the government, in big trouble that you shouldn't. It is, a high likelihood to have abuse. We're going to protect that prescription really closely, says the Canadian government. But in America, it's a supplement. You can go to Amazon and buy it. And before you go to Amazon, hang tight. There's a couple of things that you should know about it. And I think there's a couple of places where if I'm going to use DHEA in patients, this is where I send them. So yes, you can buy it off of Amazon. It is over the counter. You do not need a prescription. It doesn't mean that it doesn't work. It definitely works. But let me show you what's happening on a chemical level with DHEA. So let me show you this. We're going to come back to this slide a couple of times, and I've shown this in the past, but I wanted it to be a little more clear. So first of all, here's where we started with all of our fat, was cholesterol. And one of the first sex hormones we could make is either progesterone or DHEA. That's step 1. From DHEA, you make something called androstenedione. That's a precursor to testosterone, but DHEA is a precursor to testosterone. I want you to carefully notice that this androstenedione and testosterone have arrows that go both ways. It can flip it to androstenedione, it can flip it back to testosterone, then back to androstenedione, then back to testosterone. Testosterone to estradiol, which is E2, also has double arrows. We're going to come back to talk about this. Earlier, you heard me say that the stored fat version, the estrogen that is the form of estrogen that is in your fat cells is E1 or estrone. But once you mobilize it, once that insulin says, all right, you can come out of storage, you can quickly make that into the estradiol or the E2. We're going to talk about progesterone in a bit. So, all right. So here's this pathway. You might want to come back and look at this in a minute. I don't know if I put it in here enough times. Let's talk about the pros and cons about DHEA. So DHEA is that precursor to testosterone. And if you watched the show last week, I tried to cover this on purpose ahead of time because it's such a misconception for women that they think testosterone is a boy's problem. You have up to 10 times more testosterone in a woman than you have estrogen. It is a very important fat-based hormone for your body, and the precursor that you go from cholesterol all the way to testosterone and actually to estrogen, DHEA is in the middle. So when I look at, I don't want to do that yet. I want to go over here. So I want to start by saying with DHEA, go back to last week's show and say, here's all the reasons why a woman might want to say that shriveled up apricot has receptors that are, that have estrogen receptors on there, but they also have testosterone receptors. And your body has the ability to take that DHEA and convert it into testosterone and then into estradiol. We're going to talk about the step 2, estradiol or DHEA being the first prescription. But I want to point out that over the years, as I've tried to find sources of the best DHEA, I will tell you that my favorite one is this Julva. And you might have remembered my friend who is an OB-GYN from Texas, does a lot of education in this space. And as I look at some of the products that she's put out there, she is helps women with their reproductive health, but also she's very similar to me. She isn't going to settle for just a sprinkle of DHEA. And when I started looking for the product that I would just out of the gate send to my patients to, this Julva, which I think is very cleverly named, I have to carefully say it. Julva is one of the products that she's been out on the market for a couple of years. And I'll tell you, when women show up and say, what's the first thing I can do if I want my apricot to not be shriveled? Step one is put some DHEA on it. DHEA, again, so you'll see she has a summer special, a summer of love going on, and you can use that promo code for a little discount. But more importantly, it's supporting physicians who step outside this realm and say, hey, she's called the girlfriend's doctor for a reason. She has amazing information on her website if you want to learn more about it. But it is absolutely the best beginning. And what I can be confident of is when you're using DHEA on your genitals, it is designed for that internal external use. And step one of helping a woman feel better is not only that the skin tissue becomes thickened and that intercourse is no longer painful, but also that the activation of libido and sex drive begin with tissue that doesn't cause pain. So I've said this is the best place for beginning. If you're watching this and you don't have a physician that's willing to talk to you about this process, I will say with a huge amount of confidence that the application of DHEA on your genitals allow that first step of at least having the desire for sexual intercourse without pain. The other part that I've been really interested in, and over the years I've changed my mind a couple of times on, is topical estrogen has been something that, after the DHI trial, even topical estrogen in the setting of breast cancer was something that they would say, no, you can't do that. It's going to cause breast cancer in the woman. I can be very confident that the topical estrogens, even if you've had breast cancer, has been something that my patients and I have walked through, we've talked through, and there is literature out there saying your risk for breast cancer with topical vaginal estrogen, the studies do not support that you are increasing your risk for breast cancer. But getting estrogen requires a prescription, but DHEA is in that little graph shows, DHEA will convert to testosterone, and testosterone will convert to estradiol. So that is what is in compounded prescription vaginal estrogen, and it does require a prescription to get the estrogen, but your body can do that from DHEA. So again, what I like to show people is the first step out the gate can be safe. You don't need to go to a physician. The reason it's over the counter and you have access to it is because it's safe. I do not agree with Canada's approach that you need a Schedule II drug. But I do think that getting into your physician and having the conversation takes a bit of time. And over the course of about 3 weeks, I've seen folks just have a great response to this. There's a specific dosing schedule. I'm not going to go through that because it does change based on how severe your symptoms are. I just think that it's an excellent beginning that you do not need to see a doctor for. You can click and get that into the access of what you're looking for. All right, let's go back to those slides. All right, so this was step 2, which is here are the 2 places where we go from, step 2 was just over the counter. Step 3 is the stuff you need a prescription for. So it's actually a tipping point to say which one should go first, which hormone should you use first. And I'll be honest that this show is supposed to be for that 60, 70, 80-year-old woman. testosterone is again, last week's show, it is a very important conversation to have. But I've found that in the perimenopausal time, I'll talk the ladies into testosterone replacement before we do an estrogen replacement if their labs are normal. And we're going to talk about it in a second. Let's go. I think I have a good slide showing that. So yeah, again, prescription, which one should you go first? We're going to start with estradiol. So estradiol has 3 different ways that you can prescribe it. If you remember, estradiol was the one that is E2. Once that estrogen comes out of your fat cell, you can take it from estrone to estradiol. And this is the active form of estrogen found in your blood. If I'm going to check blood levels, I'm going to look at estradiol. And I'll tell you, when I started to have this conversation about which estrogens I write, again, here in Florida, I don't have a lot of new patients since I moved to Florida, but for the last 20 years, conjugated equine estrogen is something that I had been prescribing. And yes, I know providers out there are going to say, you shouldn't do that, you should never do that, you should never do that. But I have often found that the reaction to the conjugated it is the pregnant horse, which is a mare, so Premarin, pregnant mare's urine is where they got the name of it. Yes, it does have a higher risk than estradiol, but it also has the data that was the best to cross the blood-brain barrier, the best delivery of estrogen to the astrocyte, and the best proliferation of what estrogen does to your brain. Now, in fairness, if they were on a different estrogen, I did not convert them. If they were looking for the easiest one to start, I had used that for many years. And again, under the mentorship and under the tutoring of what my providers taught me. However, if you want to cause the biggest fight when you have this conversation with providers, go in and try to ask for the pregnant mare's urine estrogen. I think it is like, it's worse than saying Voldemort to Harry Potter. Like the ability to just cause their hair to curl when they hear the word, like, you can't do it. That's the worst thing. That's the worst thing. And in fairness, I've said, okay, it's hard enough to get patients while you educate them to go to their provider, to get a provider who doesn't just like put duct tape over your mouth saying, we're not talking about hormones. You're going to have to suffer. This is something I don't do. Find somebody else. But then if you mention Premarin, it gets worse. So here's what I've done instead over the last little bit is to say, yes, estradiol is actually a lot cheaper. So number one, estradiol has just $1 sign behind it. I should probably put a cent sign behind it, actually. So let's do that. It's cheap. It's cents. Conjugated equine estrogen, which is the Premarin, the chemical name for Premarin, man, for a 3-month supply, again, I hadn't had a patient pay cash for this for probably about a decade. Just I'd refilled it. They did their thing. I did my thing. But it was like $400 for a 3-month supply. It was incredibly expensive. Whereas the estradiol, and that's this one here, was a 2 milligram tablet was, 100 pills was like $15. So which brings you to the next question of, all right, when you look at estradiol, almost everyone agrees that a topical version is the best version. There are 4 ways you can do this. The one I left off of here is the compounding, or the creams. Let's just put the creams on there. So they mix it in a cream, they send it off to a compound pharmacy, and they have estradiol in compounded form. I did not do that. I know some people do, and that's fine. But what they're really trying to get you to do is these are all the cream, the patch, the vaginal ring are all versions of how do you get estrogen into the woman's body without activating the liver. So liver has something called first pass metabolism. When you would swallow the pill, that absorption into your GI system and into the portal vein goes right into the liver, and then it would convert like 85 to 90% of it, it also changes the sex hormone binding globulin. The number of proteins binding the hormones is determined by what hits the liver. So that huge bolus of an estrogen would activate this sex hormone binding globulin, so you would have less free estrogen around the longer you took the pill. And indeed, that's all true. But I almost never thought that you would swallow the pill. From the first time I wrote this prescription, they all said, well, just do it topically by putting it under your tongue, by putting it in the between the gums of your mouth. And I'll just show you the size of it. It's very small. It has like a chalky taste to it. And see how tiny that is? Just a tiny little pill. That's the 2 milligram. There's actually got a slip down the middle that you can break them in half to do 1 milligram. But what you notice is whenever you skip that liver, when you skip the first pass metabolism, again, you don't cause that boosted amount of binding protein to happen in the patient, so that the amount of available or free estrogen is more appropriate. But when I looked at the other options, and I offer these options to patients, but over the years, like I said, this is like the practical approach, that the patch, not bad. It's okay. If you can get the insurance to cover it, not bad at all. It's kind of a weird schedule. You do it twice a week. So I don't know. It's hard to have a routine about twice a week. The other part that I've found is that if you do any sauna, which is something I like to do, sauna, swimming, or sweating, you can find that the transmission of the estradiol through the skin it becomes compromised because the patch doesn't adhere to the skin as well after that kind of routine sweating. The other one of an estrogen ring, very popular when it first came out. Again, the mucosa on the inside of your vagina is very similar absorption properties to the inside of your mouth. And so when you put that estrogen inside that in the vaginal cuff, again, women, if you don't feel it, it's like having a tampon in. It's inside your vagina, and you kind of carry on. That you only have to change twice a month. But if you happen to have the vaginal anatomy, where if you have a bowel movement, you can expunge it into the toilet, and it's a $200 ring that often you couldn't get the insurance companies to cover until they'd failed other forms of estrogen. And so then you're looking at a toilet full of poop going, is it worth it? Real stories. They're real stories. So if they lost it, if the ring keeps getting lost, I find that it's very expensive to replace it on your own. But for some women, it's brilliant. They put it in, they don't think about it. It's just what they do. And that delivery of topical, essentially, estrogen. So let's maybe circle back and say, why don't I push for the compounded pharmacies? I do compounded pharmacies for several things, but when I look at something that I want you to be on for a few decades, I want it to be convenient, something that's in your routine. And for heaven's sakes, when you look at the cost of compounding estrogen, the rules are you need like 16 square inches with a thin layer over the skin. And then you need to let the estrogen absorb, which means you can't touch it for 20 to 30 minutes. If you put your pantyhose on, well, then you just put estrogen in your pantyhose. If you put your pants on, then you just put estrogen in the material of your pants. You didn't get it in the woman. So I don't know how many women I know that would say, let me dedicate 16 square inches and 30 minutes of standing there naked in the morning for the rest of my life, to put this into a blood level that's high enough to get the replacement for it. So I've just found that the application of how you apply it is not a nothing burger. I want something that's sustainable. And when I look at the cost of the patch, again, that probably gets, it gets at least $1 sign. I would say the ring gets double dollar signs. The creams, not only is it, in order to get enough of the cream in to get their blood levels correct, I found that one of these dollar signs is for time, like the woman's time and the amount of commitment it takes to do that. We could talk about pellets, but I have just said, why would I do that when the sublingual version is, again, for 100 pills, cost them like $15. So it's hard to talk me out of that one. And again, there was no CME that ever taught me this. There was no, it was from a provider who said, oh, for heaven's sakes, it's women. Just put it under their tongue. They'll routinely do it. All right, so that's the approach for estrogen. That is, again, now you're talking about the topical stuff or the prescription stuff, which does have places where you need to mitigate risk. Again, first step of ever having this conversation was to not be a metabolic disaster. And we're not going to cover the pros and cons of why that's so important and who would have an increased risk for cardiovascular disease or who doesn't. We do cover that. I always try to have a case study of that when we are in our 21 day, where I can be a lot more personal about the person in front of me. When I try to do it on a YouTube channel, yeah, that's going to nothing but get me in trouble. So let's move on to the next prescription, which is testosterone. Why would I prescribe testosterone? Well, for starters, it is a 10 times fold hormone relative to estrogen in a woman. And if you missed last week's show, I would encourage you to look at that. But one of the key things when I first start taking on a patient is often that low testosterone has, their labs will show me that they have a low testosterone and that they are probably converting testosterone into estradiol. So let me remind you that you started over here with DHEA, and then you had your androstenedione. So you went from here to here, and then androstenedione to testosterone, but then testosterone goes to estradiol, and this one is one of those double arrows. So when I have a patient who's got low testosterone, but I also look at their estrogen, almost always they are rapidly converting that testosterone into estradiol. But one of the key things when I'm talking to a woman about low testosterone is her symptoms are totally going to tell you what's going on. That we can go through a whole bunch of labs and we can spend a bunch of our money. But I have found that, the testosterone, estrogen are not a lot of labs, but there are a lot of ways where they start doing saliva tests and they do dried urine tests. And that's fun to study that technology. But when I'm looking at the woman in front of me saying, all right, let me hear your symptoms again. Oh, you've got low energy. Your sex drive is terrible. You're taking naps every afternoon. You can't seem to have the drive of your life. Seems to be like it. You know how you have a stick shift and you take it out of gear? It's like something's revving, but it ain't me. I can't seem to go. And I've learned that those symptoms, if I see a low testosterone, especially if she's recently perimenopausal or she's in her early years within the first 5 years of not having hormones and saying, what do I do first? What do I do first? If I see that testosterone low and the estrogen is not as low as you think it should be, she's converting all of her testosterone into estradiol. And so we replace it. And this is one of the hints I gave last week, that this is the sample that I have of a 5-gram testosterone gel. And if I was treating a male, this would be his daily dose. He would put one of these on his chest every day. And unlike estrogen or progesterone, these testosterone gels are alcohol. So they really absorb into the body quickly. Now, I will say testosterone is not FDA approved for a woman. So again, this isn't in a textbook. This isn't found anywhere that I could get CME credit for or continued medical education credit for. But when you look at the dose that most women do a great job of meeting their needs and really reversing some of those low testosterone symptoms, this would be their dose for a week. So again, a full box of these, again, a man would take 30 of these a month. So if you bought a 30-day supply, rounding up, it costs $100. I've seen it as low as $65. And it's generic. It's been around for a while. It's easy. This whole tube should get it onto that woman, and I wouldn't have her rub it on her chest. I would have her put it on her leg, because the side effect of that topical testosterone is it can make their hair grow. I was telling last week that I've seen past examples or patients, and I've seen this on like a like a Reddit page where they say, I put my testosterone on my eyebrows. I do not recommend this. I think you might grow something like terminal hairs, which are the same kind of hairs you grow under your armpits and in your groin. But the testosterone grows the androgen response of hair. And so they were putting it on their eyebrows. I'm like, I don't know. I don't think that's such a hot idea, but I've seen people do it. And what I care about most, though, is that they put it on every day. And so they say, well, I didn't get equal dosing on all seven days. I'm like, it's okay if there's a fluctuation in hormones. We know that that naturally happens in our bodies. But if your goal is for 6 weeks, I have them on this, 1 tube per week. They put it on their leg. They don't have to stand there naked for half an hour. It's really like, put it on before you brush your teeth. By the time your teeth are brushed, it's done what it's going to do. And I've had a really great response with this. I will tell my patients when I prescribe this, I tell them, there's some women who within days feel amazing, but that's the exception. Most women with testosterone, again, they're converting it to estrogen. So that's why just be nice when you put this in a woman, if it's not going to her fat cell and she's been low for a while, she'll probably convert it to that estradiol pretty quickly, and they won't see those symptoms improve for 4, 5, 6 weeks. That's been my experience for that one. All right, I am going to go to one more thing before I get to the final few slides. I want to go back to our website. I have a couple of speeches coming up that I like folks to know. One of the things I find is my duty in this community is to make sure that people who put on conferences have success. So I am going to be in Boston on June 28th for a meetup. If you're anywhere in the area, the lineup is filled with some of my favorite speakers and my, just great stories. It's been a long time since I've been to Boston, so I will see you there in a few weeks if you are attending. But this is on the Dr. Boz favorites page. You can click on there and just get a ticket. But the other one that I really am excited about are the two that are happening later on this year. In August, I get to be part of the Low Carb San Diego. It's the first time I've attended this conference. I've been to Low Carb Boca here in Florida, but thanks to a really busy wrestling season for the last few years, I've had a high school wrestler that I no longer have. He's graduated, and I will be going to San Diego for the low carb metabolic health. The lecture I'm going to give there, I have not publicized. It is the lecture on menopause brain, and it's just a great lecture. I thought I would give it on the low carb cruise that I'm going on next week, but I just think this is going to be a better way to do it. Hack Your Health is the final one, and Hack Your Health is in Tampa, where I live. So I'm super excited that they've moved the venue here to Tampa. I really want it to be a success. I'm having a bunch of my team and my staff fly in to not only be supportive of this conference, but to really help them learn about other ways they can hack your health. If you're interested, I really want those to be a success. And if you've ever seen the metrics on how these are sustainable, the tickets that sell early, yes, they're cheaper, but they are a huge safety net for the leaders who lead this to be able to predict their budget and to know we've got attraction. So you use the promo code DRBOZ, and I don't know if you get a discount. I don't get paid for this. I'm just trying to show them I want to be supportive of what these are. So just put that in there so they know we are cheering them on. All right, let's finish this lecture, and I see there's quite a few questions that are coming up, so we are going to get to those too. All right, so here we were saying, yes, testosterone is a prescription, estradiol is a prescription. I start with the estradiol, put it in the place that I think is the cheapest and most likely to be sustainable. There are other ways to do that, and that's great if it works for you, but for me, I've really found years of looking at women's behavior that's how I crack that code. But If you did watch last week's live, this was probably the most important slide that I wish every physician knew, I wish every woman knew. So this bone is trying to show you that there is AR, which is the androgen receptors. Those are the testosterone-related ones, and there's the estrogen-related receptors. So in the testosterone receptors, it is stimulating those osteoblasts to build bone, and that testosterone does an incredible job of that. When people say, I don't have low libido, I don't have a problem with that, I would still push you to check that your testosterone stays replaced, because the power of what happens when your bones do not have the strength that they have in those later years. Man, I've had more patients and more women compromise their quality of life because the bone fractured and there was nothing they could do. There are other ways to build a bone, and that includes resistance exercises, and we do all that. Again, none of them work well if you're a metabolic mess. That cortisol that's naturally high when people are stressed and when they don't sleep well, that melts bones so dang quick. The enemy of cortisol when it comes to bones is the androgen receptors and the estrogen receptors. So when looking at that, that if you remember in that chart, testosterone and that estradiol have the back and forth arrows, that these two hormones are so important for healthy bones. It's the estrogen side of things that stimulate the osteoclast, which helps to turn over that bone, to remodel it, to keep it strong. And that reabsorption of the bone has metrics that allow the osteoclast and osteoblast to build and keep that woman's bone as strong as possible until the day she dies. If there is one slide from last week's live and this week's live that I wish more people knew about, it would be this one. This is why hormone replacement therapy should be talked about more. I talk about it for peak brain performance and what it does for their mental health, but I think the most powerful argument that physicians acquiesce and write a prescription for is bone health. All right, so final thing that we're going to talk about is progesterone. So progesterone, I think, let me do something really quick. Progesterone, I'm going to go back to a slide and then up to a slide. I want to show you this one first. Let's go over here. Okay, so here is progesterone. So remember, cholesterol could take this, left turn at Albuquerque, or it could go over here, DHEA, and then have these other hormones over here. Progesterone also can be converted, there's several arrows in here that I didn't put in here, to that androstenedione, which then turns into testosterone. So they are related, but it is in a different kind of pathway than the other, the testosterone, the testosterone, the estradiol, the estrone, and the DHEA. Let me go back to that other slide now. Let's go back down here and go to here. So when I look at the things I consider about progesterone, first of all, if I'm talking to a 60-year-old woman who's not had hormones for a while, and I just go through the DHEA that she's going to use topically, and she's going to say, just keep doing that. The other part I didn't say about DHEA that I think is an important nugget is when you have sex, if you put estrogen in intravaginally, you can cross-contaminate on your partner. And you say, oh, is it that big of a deal? No, but I've had more than one patient say that he doesn't, it affects the man more than I thought it would. And it doesn't surprise me for the absorption rate in the genital area for both male and female. But to have DHEA and vaginal testosterone, again, the woman will convert it to estrogen, and there's no cross-contamination with their partner when they use DHEA and vaginal estrogen. It's why, again, when I look at the places to put estradiol in a woman, start with all those topical places, find the most economical. And you can use vaginal estrogen in women with urinary tract infections and with aging apricots, with shriveling apricots. But more powerfully is those women usually aren't having sex or they've not had sex in a while. I find them they've got other disabilities at this stage of their life. And so it's not as big of a discussion as the sexually active woman who's using DHEA plus testosterone and not using estrogen intravaginally. I found that as, again, a nugget that I don't know if I've read that. I mean, anyway, let's go back to my slides. So progesterone. If you go to every third-year medical student and say, what is the most important thing about writing estrogen for a postmenopausal woman? They'll say, you have to make sure that you write progesterone or the lining of the womb builds up and they can get endometrial cancer. And this is a history lesson when we would do that with women in the 60s and 70s, early, 50s and 60s, 1950s and 60s. And we said, God, they feel so much better. They're doing so much better. They have this estrogen. And what was happening is they did not have the ability to proliferate, or they proliferate that internal lining of their womb, but they never sloughed it. So that is what happens when estrogen is unopposed. So it's called unopposed estrogen, and that progesterone is supposed to be there to help slough the lining. Now, unfortunately, most medical students stopped getting educated there. The other part that progesterone is a fat-based hormone. Again, it's a fatty molecule. The absorption of it is not great orally. And then through the years, progestin was put in birth control pills, and then they had other kinds of progesterone trying to get it absorbed and not activated until a certain part. And there was all kinds of people upset about the kind of progesterone used in the DHEA trial. But then a great invention happened where they took that micronized progestin, excuse me, I'm saying the wrong word again. And they took progestin and they micronized it. Now, that means that they did some pretty cool chemistry which improved the absorption when you took it as a pill. So before that, we were running into the same problems that we ran into with estrogen. Micronizing estradiol has not turned out to be something that turned out to be very useful, but that micronized progestin did just really turn into an excellent absorption. It did not do that first pass metabolism through the liver that was happening prior to that. And so this has been a excellent, stable, now generic prescription since before I went to medical school in 1990. So this has been around forever. So micronized progestins have this little pill that you say, yeah, if they're on estrogen, you need to use this to help slough the lining of their uterus. But what is not educated about it is progestin has some really important uses in the woman's brain, specifically with how sleep is ignited and how the depth of sleep is achieved. And when you deny that progestin in the brain, sleep is one of the most important parts that women notice a difference when their progestin has been replaced and not replaced. The other, if I had to put one word associated with what progestin does on a metabolic level, I would call it an anti-inflammatory. Let me go back to the slide. That it is a prescription. The micronized progestin is a prescription, and it is a very powerful improvement on sleep. That's this brain here. And then the number one word that I say it has to do with is inflammation. There's another thing I was going to tell you about progestin. What was it going to be? Oh, yeah. So in that 60-year-old woman who comes in and says, hey, I do not like how I feel. I've got this low sex drive. I've got my mood is not good. I don't feel ambition. And we start throwing things like DHEA her way. And then we say testosterone, not testosterone. And we talk about estradiol. If in the same breath, you mention yet a third hormone, the progesterone family, it is also the hormone known that if you don't have metabolically strong health, meaning the insulin is low enough to allow these hormones to go where they're supposed to, is that woman moody? In fact, I have a couple of screening questions that talk about when you were pregnant, what was your weight? Or when you got pregnant, what was your weight? What was your mood the first few weeks that you were pregnant? I also go back to some of that insulin resistant questions like, how significant was your PMS? Was your menstrual syndrome? And it's not disconnected. That if their metabolic health is improved, I often find that progesterone is a nothing burger as far as mood swings and the problems we have. But if their insulin resistance is nasty, been around for a while, and the hormones have just been denied in their brain, in their body, it's like a roller coaster for this woman. So the other little nugget that I have learned is you do not, especially for the 60-year-old woman, you do not need to start that unopposed progesterone on the same day you start the estrogen. You can get the estrogen levels normal, or like, get her to like 3 weeks of estrogen. Maybe, I've even said, come back in 6 weeks and we'll take care of the next hormone. Because you do not get a proliferation of that progesterone, that lining of the uterus, when you have unopposed estrogen for 3 weeks or 6 weeks. You get it where you have it for months on end. And we're not going to do that, but it's awful on the woman who has, you're putting estrogen in, that's going to change a bunch of things. You're putting sometimes testosterone in. Even if you're not putting testosterone in, sometimes she's reverse making that. So now you get 2 hormones bouncing around. And then adding progesterone, which is known for being the moody one. If your metabolic health has been compromised over the recent years, oh man, it is just like a torture session for that woman. Don't do that. You don't want to miss it. She needs to be on it, but she doesn't need to be on it the first day you write that estrogen prescription. So yeah, those are the top findings that I have in my little list of questions. And I do want to just say, I see that the time has gone by. You can tell I like talking about this. I want to make one more announcement before I go to questions, and that is, next week, I'm on the low carb cruise. We're flying to Seattle and we're going to be on a cruise to Alaska. I'm going to be lecturing to the folks that are on that cruise. I want to say thank you for the folks that have organized that and have invited me to be along again. But there will be a lecture that I loved. I tried to record the dang thing twice, and the recording for my friend and colleague, we didn't have the video on. So we have a substitute video about the topic that we discussed, and I just really hope you like it. It will air next week. So the following week after that, I will just be off. So this is my permission. You can say in the comments, do I have your permission to take a break from having a live lecture the week that I'm on vacation with one of my kids and my husband. So let me go to your questions and go from there. All right. So Trish writes in, can Jolva help with sex drive? Yes, that's the key to this topical DHEA, is that you will turn it into testosterone. And is it safe to use on one if one has had a uterine cancer and had a full hysterectomy? Yeah, the good thing about uterine cancer with a full hysterectomy is the organ that had cancer is no longer there. One of the best parts about what testosterone does to the female anatomy is the vestibule. The vestibule is, if you look at the correlating anatomy for men and women, the vestibule in a woman is the same as the corpus cavernosa in a male, which is the part of the penis that engorges and is part of that physical transformation when there's arousal. And when a woman has no testosterone, that anatomy is the reason their apricot shriveled up. That DHEA and testosterone, the DHEA converted into testosterone by your own little cells doing their job, is an incredible response. And the answer is yes. I hope I don't get banned from YouTube talking as detailed as I am here. Debbie says, I always heard you shouldn't do any HRT after 65. Is that true? The answer to that is no, it's not true. But it is complicated. And not complicated that there's no answer. It's complicated that your individual physician needs to do some work. And I contend you need to do the work. It is one of my favorite discussions that we have, you can say behind a paywall in our 21-day class, where we give more individual answers to the questions, and we walk you through an intense, what does it mean to be on a ketogenic diet? How do you get ketone numbers and blood sugars like mine are every week? That's the class that teaches it. But it's also the steps needed to say, if you want your doctor to write prescriptions for hormones of women over the age of 65, the biggest reason they're going to push back on that is that the first year of that could have an increased risk of cardiovascular disease if your markers of cardiovascular disease, of metabolic health, are at increased risk. Now, the data they have to use that is from, partially from that WHI trial where they said, yeah, they were smokers, they were overweight, they had high blood pressure, they were very ill women. And because, I don't know, they didn't know better. I have a bunch of reasons why they did it, but whatever. The punchline is the 65-year-old woman still has a higher risk of fracture without estrogen, and a higher risk of cardiovascular disease if she never gets on the estrogen for many years. That first risk is where the pooled data looks like there could be an increased risk if you have these really high cardiovascular markers that we go through when we're looking closer at how women can profile for that first year of hormone replacement. But even when you take those numbers out and you go back and they have analyzed, do these women really have an increased risk of having a heart attack? It was not worse than being off of estrogen. And so that's the part where it says, yeah, the women at that age, age is one of the biggest predictors for that cardiovascular disease. And when you added estrogen plus in a setting where lots of cardiovascular markers were elevated, that's where they said, oh, it's going to increase their risk of cardiovascular disease for the first year. And so for some of my, my patients and my closest, friends, I say, I'll manage your heart disease for the first year so that your doctor will write the prescription after the first year. And but they usually have to take the 21-day course. They usually have to say, I'm not saying you're going to dabble in a ketogenic diet. I'm going to say, you got to make ketones. You got to fix the chemistry that you are in charge of. And that's no simple task if you've been insulin resistant for many years. So yeah, don't let that never button be on your list. Can a 24-year-old postmenopausal take HRT? The answer to that is the same as Debbie's, yes. You got to learn how to take care of the best version of you though, and that means your metabolic health comes first. That's why this topic is just in conjunction with the education that we try to give folks. Can it help a prolapse uterus? Prolapse uteruses are again, the danger of a prolapse uterus is how dry that skin gets, how dry that the perineum gets when that prolapse happens. It doesn't stop you from prolapsing, but the danger of that mucosa getting dried or cracked is infection. And so one of the buffers against that cracking and drying has been topical DHEA, testosterone, and estrogen. But prolapse, one of the other places that I think women, especially if you've had it for years, is a pessary, which is really old-fashioned, and about several OB-GYNs don't like them, but I just think it's a great bridge to get you to a surgical time. Often I've seen this more than once, where the woman is worried about her prolapsed uterus when what she should be worried about is her cardiovascular risk during that surgery. And it is a major surgery, no matter which way you cut it, especially because you're going under anesthesia. And the biggest worry I tell patients about anesthesia is, when you let me control your blood pressure for the 3 hours or however long it took to do a prolapse uterus, sometimes those brain cells get stung and their memory does not come back to normal. The OB-GYN is not the person who takes care of that. They send them to the internist, and I get to watch their decline over the next 2 years, saying they weren't healthy enough for the surgery. Now, the prolapse uterus seemed to be, you go into the OB-GYN or the pelvic physician, and they say, just get surgery. And I'm like, just use a pessary until your metabolic health is healthy enough to then have a lower risk of that, if that's what you still want. The other part about prolapse uteruses is when they lose the 70 pounds, yeah, the uterus still prolapses, but not nearly as badly. All right, good questions. I'm going to keep going here because I love these questions. I am 5 years since I went through menopause, and I'm still having hot flashes, terrible sleeping. Is it too late to see? No. The first thing, especially with hot flashes, is the estradiol under the tongue. It is like within 10 days, they do feel better. They feel so much better. You're going to have to go to your doctor and have this conversation with her, right? But I can't tell you how much better their brain feels within, especially the hot flashes when you get that estradiol by about the 7th, 8th, 9th day. It definitely helps them to feel better. So no, it's not too late. And boy, oh boy, don't spend your life doing that. If it hasn't gone away by 5 years, I'm telling you, you are, and that's a pattern recognition for me that she will have hot flashes until she's 90. I've met those women. It's terrible. Help them, help them, help them. Aloha 22. Oh, you're such a good and trusty. They're here every week. What's the first hormone to address in perimenopausal mood swings and rage? I find it quite startling and scary when it happens. Yes. You know what I look at here as I go to that lab test and look at the testosterone and estrogen levels? Almost always your FSH and LSH, those are pituitary hormones saying, how well are the ovaries doing? Are they keeping up? And they'll give you a sense of whether or not that FSH, that ovary is doing what it's supposed to. But it'll still testosterone and turn it into estrogen. So if they're not having hot flashes, they're just having mood swings, I will find that their testosterone is very low. And their estrogen, they're stealing from the testosterone to keep the estrogen stable. But the testosterone replacement is easy, quick, and not too expensive. And again, 6 weeks of that, and they really can feel better. The other part that I've seen with when the mood is doing that is to consider progesterone replacement, that micronized progesterone in a pill form after you do the testosterone. Like sometimes the estrogen isn't the part in a perimenopause that's going to give them the best symptoms. That testosterone replacement can be a huge relief. And eventually you'll have to add the estrogen, but at least most people do. I've had a few people it's rare that if you replace their testosterone, they just converted to estrogen so quick that their estrogen levels were always good. Their bones were good. We never did the extra one. So I would start with testosterone and call that the best approach for that. Okay, 2 questions left. And okay, does DHEA help after hysterectomy? Yes, DHEA again is helping that anatomy for and the thickness of the skin of that perineum there. Stephanie says, last week someone asked about natural options for estrogen, progesterone, testosterone. So when I look at natural, when I hear that word, I still want it to prove to me that you're getting enough to be worth, because there are risks. I didn't cover those as much today, but adding estrogen, progesterone, and testosterone, you should be checking the levels. And I mean, the conversation about natural replacements, it's like the same thing with, metformin and curcumin, that the molecule you're after is still in them. It's just that the one from the FDA, and I know people like to hate on prescriptions on this channel, but the one from the FDA is regulated. It is going to be the most cost effective. It's something I can trust. And when you get it from the natural places, you just have to sift through a whole bunch of other particles inside that supplement or replacement or treatment to get the one molecule that actually fits in the receptor that's going to change the outcomes for your hormones. And I just wouldn't play with it. I would say, you do live in America. We do know the science of how this works. And I think it isn't such a bad thing to have the most purified version of estradiol for $15 for 3 months. I mean, I just think save those resources. All right, that is the last one of the week. I do want to say thank you, and a special thanks for all the pin chasers that showed up this morning. One of my favorite hours of the week. We'll see you in 3 weeks, guys.